Thank you for tuning in to A Conversation That Matters, brought to you by May. May is a digital health platform created for us, by us. At May, we offer pregnancy tracking, virtual live childbirth education classes, personal care coordination, and we match our members with a local doula in their area. We are a small but strong group of women, mothers, and birth workers who are dedicated to empowering you to have a happy and healthy birth. Sign up today at meetmay.com/sign up and enjoy this important conversation that matters. Thank you everyone for joining me today for this conversation that matters. My name is Lydia Harris. I am the lead of content marketing strategy here at May. I am a birth doula, postpartum doula, VBAC practitioner, and doula trainer myself. So everything we do here at May is very near and dear to my heart. We are here today to kick off and celebrate Black Maternal Health Week this year. And today we are going to be discussing various pain medications in the labor and birth space. And with me today to have this wonderful discussion, I have Dr. Allison Lee, I have Dr. Michelle Owens, and I have Rachel Wade. So I would love for each of you to kind of introduce yourselves, tell us your work and why you are here today to have this conversation. And I'll start with Dr. Allison Lee, please.
Thank you so much for having me. I'm so excited to be here. I'm an obstetric anesthesiologist. I've been in practice for over 20 years. And I am dedicated to taking care of pregnant birthing people. And being an obstetric anesthesiologist means that you've done an extra year of training. So in this field, and as I said, I've been practicing for a long time. I practice at the University of Pennsylvania. And I'm also involved in work in health equity and research. And so Black maternal health is super, super core and important to what I do.
Thank you. Dr. Owens?
Hi, everyone. My name is Michelle Owens. I am a maternal fetal medicine subspecialist, which is known to a lot of people as a high-risk OB doctor. I am in Jackson, Mississippi. I work for Ascension Healthcare, but I'm also the clinical director for May Health. I am one of the leads for the maternal health initiatives in the state of Mississippi, and also run our maternal mortality review committee. And so through the course of my practice, have had an opportunity not only to care for Black birthing people and other marginalized communities, but I also have had an opportunity to do work in the area of health equity as it pertains to working to reduce the disparities that we see between outcomes in pregnancy as it pertains to Black birthing people and their other counterparts. And so it's just an honor to be here with all of you.
We're grateful to have you. And Rachel?
Yes. Hello, my name is Rachel Nance Wade. I am the Vice President of Marketing and Doula Development here at May. So I am honored to be on this panel with some of my incredible colleagues, but I am really here today as a mother, representing a mother who has had 3 deliveries, births with various levels of medicated and non-medicated experiences. So I am excited to participate in this conversation and kind of talk about some of what that has been like from the mama side of the seat.
Thank you so much for taking time out of all of you out of your busy days and schedules to come and have this collaborative conversation. If you are watching this, video, then you are aware that this work is incredibly collaborative and it takes all of us. And so I'm really grateful that we all have this opportunity to hear from experts, whether that is the mothers themselves or from our providers over here. So I would really love to kick off this conversation with Dr. Allison and ask you, could you please explain to us what is an epidural? And could you clarify what it is, what the medication is, and kind of walk us through what it looks like to receive an epidural?
I'd love to. So I have toys, props here with me. And I think the best thing to start with is explaining that the epidural is placed in the lower part of your back. And you know, your spinal cord and your nerves run, and they're protected by this bony cage that is the spine, and the vertebral column is the medical term. And those are the nerves that that transmit the signals of pain from your uterus and your birth canal. And so that's the reason that we have to approach it from your back. So we actually go in between these spaces in your spine. This model is very, very curved, and you'll notice that when you're getting an epidural, we actually ask you to curve forward, and that helps to open up these spaces so that we can get into that very small space. So the epidural involves being able to get into that space, epidural space that's very close to the nerves in the back. And I know it seems very scary to a lot of people, but just to explain, we go way below the level of the spinal cord. It's in the lower part of your back. It's a sterile procedure. There's numbing medication that's given to you first, so that the procedure should mainly feel like a lot of pressure as we get into that very narrow space between the bones in your spine. And I'm going to put this down for a second and explain that once we've located that spot in your back, the epidural involves placing a very, very fine catheter. And I have one here with me. I've heard people describe it as about the size of a guitar string. You know, it's very, very small. It's not something that you're going to feel once it's in place. And it gets taped to your back once it's in that spot. Once it's in the spot, we can actually leave it there, similar to how you have an IV that's placed in one of your veins. We're able to continue to deliver a medication through that catheter that's in your back until you deliver your baby. And the wonderful thing about an epidural, and of course, I'm coming from the point of an anesthesiologist, is that it gets you out of pain. And then once it's there, it's also available to use in case of an emergency. You know, as you know, labor can be unpredictable. You could end up unexpectedly needing a C-section, and we can inject stronger medicine through that to get you numb for surgery.
Thank you. So, Dr. Allison, how long from the time mom is like, I want an epidural, from the time that she says that to the time that she is now out of pain and, you know, it has done its job, what does that time frame look like?
It's quite variable, you know. Sometimes it does take several minutes to get set up for that. It takes a few minutes to get your back prepared. It's a sterile procedure. And then it can take several minutes to find that small spot. Sometimes it's very easy and it's in a matter of just, you know, less than a minute. And then there are other cases when it, you know, it can be a little bit more challenging because of your body size, or if your, you know, spine's curved and so on. So I would say, and then once you get into the right spot, it can take anywhere from 3 minutes up to 20 minutes, potentially, depending on, you know, the little nuances and the technique that's used. So that's why I actually advise patients when they can, if you think that your spine's curved or there could be some challenges, you know, placing it, I would say don't wait till the very late when you can't stay still and you can't, you know, cooperate with the positioning very well, because, you know, when you're able to be calm and get in position, that makes the whole process smoother.
Mm-hmm. Right. One of the things I've noticed in my work as a doula is kind of that struggle of trying to get mom to stay in place. And I think that's something that doesn't get discussed as often, is like, and Rachel, I'd love to hear your experience with this as well. It can be a struggle with those contractions coming as they get stronger. People may not realize, like, mom has to stay still because, like you said, this is a procedure. This isn't, you know, something that's very low level, and you're doing a really big, important job. And so does it ever get to a point where it's too late to get an epidural?
From my perspective, it's almost never too late in that you could even be fully dilated at 10 centimeters and you can still get an epidural, especially if, for example, this is your first pregnancy, because as Dr. Michelle will tell you, in your very first pregnancy, that period from fully dilated to delivering the baby could be up to a couple hours. And if you're in severe pain, you don't necessarily want to be in pain for that long. But if you are a mama who's had a bunch of vaginal deliveries and things are happening really fast, that may not be, the baby is coming down. That may not be easy to do at that point.
So Rachel, oh yeah, I was going to say, please speak to this. Oh, you're muted.
Sorry, I muted myself because my alert's going. That was me in my first pregnancy, actually. So I really was insistent on laboring at home for as long as possible. I had a doula with me on the phone actually for most of it, but what I wanted to get through as much as I could. I actually arrived at the hospital at 9.5 centimeters, but I was ready for an epidural at that point. I don't think at that point, because that's another thing too, is first time mom, I was really anxious about pushing and didn't really understand as much of getting through that transition was that like big piece. Once I got there, but I was about 9.5 centimeters. I was like, is it too late? And it wasn't. I was able to do it. My experience was then it did slow the progression down of that. The next phase, it slowed down when I was able to push, but it gave me a moment to rest. But again, to your point, when you're in active labor and having active contractions, the process was very difficult to just kind of like stay still and breathe through and be as still as you need to as you're experiencing some pretty significant contractions.
Right. So, Dr. Michelle, I'd love to get your input on this as an OB. How do you manage these conversations? How do you help a mom who might not be as, decided as Rachel was, like, hey, I'm here and I'm ready? If you have someone who's kind of weighing her options, how do you manage that conversation?
Well, I think the first thing is anticipating that conversation will need to be had or need to take place. I think one of the things that we, just like Rachel said, everybody comes to this process, especially your first time, with certain things that you are focused on or that you're thinking about. And that's why I think having support people and really a team approach to your birthing plan, or even if you don't have a written down plan, like what your expectations are and the things that are important to you, having a conversation with your healthcare team about those in advance is really important. But so typically, because people think about the pushing part and they think about the labor part, they think about the option for a cesarean delivery, but like how you actually go through it and get through it, and the differences in even the stages of labor and how people handle them can vary very widely. And so I think one of the things is just to talk about what their goals are or what their ideas are, and also not just to stop there, but kind of digging a little bit into the reason behind them. Some people choose to do it natural because they have been told that like somehow you get a medal for not having an epidural or having any pain medicine, or that pain medicine somehow is a sign of weakness. And we know that those are not true and accurate. That is just people's opinions. Everybody has one, but opinions aren't facts. And so I think it's really important for people to recognize, like, well, why do I feel this way? And if I want to have a natural birth, then what are the reasons why? You can talk about that with your doula. You can talk about that with whoever's going to be present with you, and talk about it with your healthcare provider. If you happen to see an anesthesiologist in advance, for whatever reason, then having those conversations is really important. Some people say, I don't want an epidural out of fear. Plain and simple. They think, well, I don't know that I'm going to be able to stay still, and if I move, I'll be paralyzed. Or I don't like needles, so I don't want a big needle in my back. Those kinds of things. So I think finding out why is really important. And then allowing people to understand that there are lots of different ways that we will get through the journey. And like there are lots of different roads that get us to the same destination, and that there's not necessarily one road that has to be better than the other. It's just about your preference, and letting people know that they have options and when they have options. I'm really concerned about the way that we have allowed fear to be one of the predominant emotions in pregnancy and in birthing. And so how, rather than presenting people with options and giving them information so that they can make the best choices, how people get suggested or proposed things, and they use fear as the reason or the rationale to do or not do something. And so I think just being able to address the things that people are concerned about and let them know that some people do it without pain medicines and others don't. And that one's really not better than the other. It's just about choosing the thing that's right for you. But encouraging those conversations, not just on a superficial level, like epidural, yes or no.
Right.
But if they say no, then let's talk about why that is, not in a judgmental way, but just to learn more information to make sure that they have scientific or good, solid information or reasons. And then the other part is, if they say yes, then let's talk about what that's going to look like and what's going to be required. And, like some people are told that it's too early for an epidural. Some people are told it's too late. And while we've had people here who've said that it's hardly ever too late, a lot of women in other facilities don't get that same message. So knowing what the culture is in the institution or the place where you're delivering is also a very important part of that, because that can also have an influence on your overall view of your experience.
Yes. And that's why I'm so grateful that we are all, kind of gathered here together to have this conversation, because there really is power in knowledge. And I really love the fact that we're kind of dispelling some of these myths, and we're able to acknowledge why someone wants to get an epidural, why someone does not want to get an epidural. And I think another common myth that I hear in my work is the all or nothing argument. Well, it's either I'm fully natural and I'm feeling everything, or I'm having an epidural and I have to have this cascade event that I've heard so many times. And so I'd love to hear from our doctors, as well as from Rachel, what are some other pain medications or pain management techniques that you guys use and implement? And I'll also share some of mine as a doula when you all are done.
Well, from my perspective, the techniques that I usually get involved with involve medications. And I know that many people have heard of the fact that you can get some medications through your IV or as a intramuscular injection. And I think those are fine. And especially sometimes they can help you cope for a while in labor. I just want to point out, though, that people forget that if you're getting a medicine in your IV, it's not necessarily safer for you or the baby than an epidural, because anything I give you in your IV generally crosses over to the baby. And so especially if you're getting that medicine right before delivery of your baby, that could also, slow down the baby's breathing or make the baby a little more sleepy. So it's not like all or nothing, like one is definitely better and one is not. A lot of people will have heard of some inhaled medications. There's nitrous oxide that's not available everywhere. And that's another type of approach that can help you cope with the pain. We often don't use it as anesthesiologists because we think that the epidural is more effective. But if that's the patient's preference, or they maybe don't qualify to get an epidural, say, because they're taking blood thinners, that can be a good alternative. And then when it comes to epidurals, I just wanted to put a plug that we think that they're very safe, but nothing is without risk. So that's why you should discuss those risks with your provider. So for example, if for some reason you need to take a blood thinner because you had a blood clot in your leg in the past, if you show up in labor and you're still having the effects of that blood thinner, an epidural is not right for you until that medication has worn off. And The other thing is that, Dr. Michelle brought up the fear of being paralyzed. And I just want to make sure that it's very clear to people that that is so, nothing's impossible, but that is so rare and so unlikely. I know that there are a lot of, horrible stories, tragic stories that are maybe, especially happened maybe decades ago, and, they still persist, as lore in the community. If you move during an epidural, because we're in the lower part of your back, we're usually not anywhere near your spinal cord. So if you move, usually that needle could jump where we don't want it to go, but the worst risk usually is that you'll get a really bad headache. And that's the risk. It's not that we're going to just pierce your spinal cord. That is so extremely unlikely. So I want to, people are worried, well, if I move, I'll get paralyzed. That's not really the concern. Did someone want to say something?
Oh no, I just said thank you. Thank you for that, because it's a very common fear. You hear that way more often than you'd think. So thank you for, clarifying that.
Right. So, everything has those risks, and that risk of a headache, if you're able to stay still, is about less than 1%, So, you should sort of put those risks in perspective.
Yeah, I think one of the things that's really important too is while there are always risks to anything, then the other question is, well, if something does happen, then what are the options that are available? And so, if you do end up with a headache, there are ways that headache can be treated. There are some less invasive ways with, medications and other like physical or mechanical techniques that we use. And then there are some that are a little bit more invasive that can also give you relief. When I think about pain control, though, going back to the original question, at least from an OBGYN perspective, our anesthesiologists on OB are of great help, because my anesthesia colleagues on the labor and delivery floor can provide far more pain relief, than I really have in my toolbox as an OBGYN. There are a few things, and we both have the abilities to order and administer medications through the IV. Those medications do kind of make people feel a little loopy and take some of the edge off, and they can have an effect on the baby as well. Fortunately, those medications, most of which are opioids, or what people would think of as like narcotics, I guess the same. Those medications, we do have the ability to reverse. So there are medications that we can give to reverse the effects of those medications. The other, I guess, disadvantage of those medications is that they don't last as long as, say, for example, if you had an epidural where you could be dosed more regularly or consistently and at a lower frequency, right? So the time interval might not be as frequent. And so those are some options. We also can occasionally use a pudendal nerve block. And so the pudendal nerve is a pelvic nerve. So if you're thinking about a person who's positioned, say, for example, on her back for birth, and you're actually looking at the vagina, we can deaden the nerves through the vagina around the vagina to be able to provide some relief in that lower part of the pelvis. And again, it is, use regular numbing medicine, kind of like how a dentist would numb your medicine, would give you numbing medicine for a dental procedure. Only we're doing it, in the area of the vagina to dull the innervation or the sensation of pelvic nerves. So we do have that option available. If you need, for example, if you have a tear, or if we have to cut an episiotomy, so if we actually have to make a small cut in order to allow for delivery of the baby, then we can use local anesthesia, which is just administered through a syringe to be able to provide relief to the area that is either actually cut or the part that's been torn. So those are really the the big options that are available from an OBGYN standpoint. I always tell my patients I'm happy to help however I can, but the truth is that the real people who come in and save the day on the pain relief side, if you actually want, you know, lasting pain medication and relief, the anesthesiologists have a whole lot better tools in their toolbox than we do. But we do still have some options for those people who decide that that is not what they want in their experience.
I just want to tag on, you had asked about the medications, and I think I didn't talk about what exactly goes into the epidural. And it's usually a mixture of the local anesthetic, the numbing medicine that Dr. Michelle mentioned, and a mixture combined with an opioid. And that mixture together works really well. They work better than apart. So they work together synergistically, is what we say, to give you pain relief. So it's a little bit of numbing and a little bit of pain relief with the opioid. And that opioid, the most common thing we use is called fentanyl. And I wanted to bring that up because a lot of people hear fentanyl and it sounds very scary to them because it's so commonly talked about now as a drug that's used in the streets. And I just want to remind everyone that we have been using fentanyl for decades and decades safely for medical care because it's medical grade. We know the exact dose we're using it, and we know how to use it very safely. So I don't want people to be scared if they hear that they're getting fentanyl from their doctor. And then that numbing medicine numbs up the nerves, helps relieve the pain. But don't be surprised because that same numbing medicine can also numb the nerves that affect movement. So you might feel like your legs are heavy, and that's why you'll be told it's not safe to try to walk around while you have the epidural running. So it's a delicate balance between making you not feel too heavy and being able to push and also being able to control your pain.
Yes, thank you. Because, you know, I do believe the only thing, if you already have a preconceived notion of fentanyl, you have an idea of it, it's one thing, it's already scary to hear, hey, we're about to administer this to you. It's a whole other level of, in some instances, betrayal to hear after the fact, oh, that's what I was given and I didn't know. And, you know, you might have told them, they might have signed something, but they might not have registered it. And so I really appreciate, again, just being able to have this all laid out in a succinct way in one place for people to, you know, kind of use as a resource. And I also wanted to go back to Dr. Michelle real quick, because when you mentioned that snip, I could already feel the audience go. And so can you please speak to that real quick and just talk about just how not common that typically is?
Yeah, you know, I had a moment where I was kind of playing that through in my head. Like, do I really want to bring it up? But we don't look, this is what we do at May. We are transparent and open, and we want to give people an opportunity to have access to good, solid information. And so episiotomies or are just where we take surgical scissors. And so when you talk about the birth canal, there's the vagina, but there's also a series of muscles that create the bottom of the pelvis, what we call the pelvic floor. And in the process of birthing, those muscles, as well as the vagina, just very much like the cervix, they all undergo changes in order to facilitate the passage of a baby through the birth canal. And so in order to have that happen, those muscles have to kind of thin out and relax. And a lot of times pushing kind of is instrumental in that process. So it serves two purposes, right? It helps to expel the baby through the birth canal, but it also has an effect on the muscles and the tissues around, and the nerves, as a matter of fact, because for people who push for long periods of time, there can also be changes in there in the innervation, et cetera. So when you've performed births, you kind of can get a feel for, as the baby is coming, sometimes there's just a small bit of muscular band that's kind of holding things up. And so there are lots of techniques that can be used, right? There's perineal massage and other things that you can do to kind of help to get those tight muscles to relax a little bit to help facilitate delivery of the head. But occasionally, as the baby is coming, there may be a reason or a need to actually cut that band or make a small incision in that area so that the baby can be delivered. Sometimes that's because you need to get the baby out quickly, or it could be sometimes for maternal exhaustion. I've had moms who are like, I can't push anymore. And you feel that little bitty band and you're like, if I could just get through it, so you can make an incision there. I think the reason that it can be a little cringy to people is because I think there have been a lot of concerns about whether or not those decisions are always made in the best interest of the patient. And also if they have always been made with the patient fully aware and in agreement with that process. And so just historically, I think that there have been times when those things have been called into question. And so I think it's really important. Again, I believe in having conversations in advance. Sometimes you don't have the privilege or the luxury to do that. But I do believe that if an episiotomy is going to be cut or those kinds of things, it is standard to have that conversation with the patient and to explain to them why. And to say, hey, I feel this little band here. I really think if we snip this, I can go ahead and do this and we can get the baby delivered. And then if the patient says, no, just give me a little bit more time to push or what have you, as long as everything's looking fine with the baby, there's not a reason that you couldn't necessarily continue along that way. I do believe that needs to be communicated though. And so, yeah, episiotomy is not a bad word. And there are plenty of times when we've used it and it's been helpful in order to save a person, from perhaps a few more hours or a much more elongated period of pushing. It's been helpful for those women who do become excessively fatigued and have kind of given everything that they have when they're right at the edge. But it is something that I think should be made, a decision that should be made through shared conversations and at least with good informed consent.
That actually ties very much into something I was thinking about before, because when we're talking about education and the importance of transparency around all of this, what I will say is for myself going into this process, I didn't necessarily understand the implications having an epidural and having less sensation in that area would have as I pushed. And what I'll say is, from my perspective as a first-time mom, having gone through transition and then kind of gotten there and needed a rest, chose to have an epidural, I was not as fully educated about the implications it would have on the pushing part. And I actually did end up having an episiotomy my first time. Subsequent labors, I had 2 more deliveries where I did not have medication and I did not tear because I was able to feel that sensation more in that. So I think that there's and transparently, that conversation of this is happening to you, I'm performing this procedure to get your child out, did not happen with me. I was not spoken to in that moment. I had gone through labor. Was tired. And at that point in which that happened, it was not communicated to me. There was not an explicit conversation. So I think that awareness of kind of not just what your experience will be when you have an epidural, how you'll feel immediately, but also the implications in terms of how your labor and birth will go, and then also the recovery, because your recovery is different when you have an epidural than when you don't. So I think that's another step of the education piece that's really important for especially a first-time mom, that you might hear this is what's going to happen to you as soon as you get the epidural, but you don't necessarily learn how does that impact the next step, and then how does that impact your recovery.
Yes, I would love to hear from our doctors about that recovery piece, because she's absolutely correct. There is a difference in the recovery time as well as, how it looks, et cetera. So Dr. Michelle and obviously Dr. Allison, if you have anything to say, I would love to hear your guys' input on that.
So, because my experience, so I'll let Dr. Allison speak to the recovery from an epidural, because the interesting thing about epidurals is that once they're placed and they're working well, like you can use them. You're not really necessarily time limited, so to speak, on how long they can be there. So I've been at institutions where the epidural has been placed and it's been used for anesthesia after delivery for a set period of time. I've also been at places where the baby comes out, and once we know that, mom's not bleeding heavily, they pull the epidural before the patient even is wheeled out of, that birthing room into another place. So, so the way in which epidurals are used can kind of vary a little bit when you're talking about postpartum pain control. And also even when you think about how much control you have or you feel. As a person who has had an epidural, they still call me mom, and I did have one. That was not my original intent. I wanted to do it natural. I labored for 17 and a half hours. And then I got an epidural, and it was the best sleep I think I had ever had while I was having a baby. So, but what I will say is that in the recovery piece, like sometimes you get really heavy legs. Sometimes that's related to how much medicine you get, or the timing of when the epidural was placed. And so for us, for the postpartum pain control is different when you have surgery. So if you have a C-section, your pain control needs tend to be higher than if you have an uncomplicated vaginal delivery. Now, if you have a complicated vaginal delivery with a significant tear, then your postpartum pain control will be different. And let's add on top of that the fact that we all have a different threshold for which, we feel pain. So there are some people who have a really high threshold and others who don't. And so all of those things kind of have to come together. And our anesthesia colleagues are kind of like chefs, right? They put together the right ingredients to give that particular birthing person, that laboring person, that postpartum person, the right pain control. Typically for us on the OB side, it's more medication based. And by that, I mean usually oral medications or some medications that can be given through the IV. Like we use non-steroidals or NSAIDs, which are like, most people can think of like ibuprofen or the liquid ibuprofen, which is ketorolac. So there are medications that we can use that can be given in a variety of ways. It can be given rectally. Yes, that's not just for babies. It can be given by mouth. It can be given through the IV. We also have other pain medications, narcotics, and other types of medications that we can give, opiates, that we can give orally or through the IV as well. But the recovery is really going to depend on how complicated your birth is, and then also on any other pre-existing conditions that you may have, because those are also going to factor into how well you recover. People who weren't very healthy before procedures don't miraculously become super healthy after, right? And so you bring that into your recovery experience along with you. So it's not just what you've experienced, but it's all of the things that you had when you came into that, into your birth, that you will also carry with you and will influence how your recovery goes.
And if I could jump in, I think you said some things that I want to sort of drill down on because they're so important. I hear a lot of women feeling like they sort of were forced a little bit or pushed really hard towards getting an epidural. And I want to mention that there may be reasons why you'll be strongly encouraged to get one because of your other health concerns. And so that's an opportunity to have that conversation about do I need to get it now? When is the right timing? And even if I do get it, if I really don't like the feeling of my legs being heavy, are there things that you can do to back off a little on the medicine that I'm getting? And there's sort of room a little bit for negotiation. And so you should be able to have that conversation with your provider. The other thing I wanted to mention is that how different every single individual labor is. Some people are going to feel severe pain when they're 1 centimeter, and there's some people who can tolerate the pain of labor for hours until they're almost fully dilated. And it doesn't mean you're weak. Everyone's body is different. And I've even seen people with different pregnancies in the same person can be different. So, it's really important not to be comparing yourself to someone else's experience. And then the couple more things I wanted to point out was that pain relief can allow you to rest, but most times the medicine that we're giving you in the epidural is not going to be sedative. Okay, so it's going in your spine, it's working on receptors in your spine, but I feel a lot of people think that the epidural is going to make them sleepy, but it may allow you to rest, but it's not sleepy medication.
Mm-hmm.
And then the last thing I wanted to bring up was the idea of pushing with an epidural. We often say as anesthesiologists, the most important muscle for pushing is your diaphragm. You can push even if you're numb, as long as you can bear down and take instructions. But I do understand that if you're not feeling very much, it can be a little confusing. So I wanted to make that distinction. I think Dr. Michelle would agree.
No, absolutely. I think that, and P.S., thank you for clarifying about the about sleep. That was just because I went into labor at night and I had been up. I worked that day. I went into labor that night. I had been up the following day. And so when I went to sleep after my epidural, it wasn't because of the epidural. It was because I was exhausted. It was sheer internal exhaustion. But I think that's really important, to know exactly what it is and what it does. And yeah, that's not going to put you to sleep, but it was, as a matter of fact, that was my biggest problem. It wasn't the pain as much as that I just felt so exhausted that I felt like I was losing my focus. And every 2 minutes, that pain came back and I could breathe through it, but I was just so tired. But yeah, really good, all very good points.
Same for me too. I think I would say the same thing. It was like in that moment, it wasn't so much like anything except I just needed to catch my breath, and it allowed me to kind of do that and then recharge to push. But it is a very interesting kind of different sensation, and feeling is very important for that part of labor, because it does allow you to kind of feel when your body is doing what it needs to do naturally, and it doesn't feel like you're working against it as much. And so from a mama perspective, as I experienced both, I would say that sensation for me personally, as I was delivering without the epidural, I was able to kind of guide that more. But to your point, every pregnancy is different, because that first pregnancy, man, after I was like, I need a break. And that was how I got through. So I think, to your point, not comparing yourself even from one to the next within your own, because also you're older, your body is different. You're in a different position every time you have a baby. And it's really important, I think, as well.
Yeah, no, and I think the other thing about, you said something about slowing things down. And I think a lot of people are hesitant about pain relief because they worry that it's going to slow things down. And so while, yes, there is plenty of scientific evidence that things do slow down a little bit more, slow doesn't necessarily mean bad. And I think sometimes people don't understand that. And the other piece is, how much does it slow it down, and what does that look like? And you're not talking about now you're going to be in labor for 2 days when you were originally going to deliver in 4 hours. Like, that's not what is meant. And so the influence of epidural, while it may slow things down a little bit, I will just say that from my own clinical experience and the patients I've cared for, there have been some patients who I have cared for who have been they've been so uncomfortable. And because they're uncomfortable, they're so tense and so tight. And so my doula girls can talk about this, but so they don't have the right coaching, or they have not been taught how to relax. And so I've seen epidurals placed in those people, and miraculously they go from 4 centimeters, because everything down there is so tight. They finally are able to relax their belly and relax their pelvis and their pelvic floor. After they get that epidural, all of a sudden they relax, and next thing you know, they're 9 centimeters. So it doesn't, and it just because epidurals can be associated with slowing things down, it doesn't mean, number one, that slowing things down a little bit is bad. And number two, it does not mean that that's going to happen, or that happens every single time. There are definitely times when I've seen it myself speed the process up. So I think you kind of hear those things, and you have to take them with a grain of salt, knowing that that is not always going to happen in every case, and your case may be totally different.
Yes.
Since we're talking about a little bit about science, I just want to jump in for a little bit, just to explain that there's actually a type of epidural called a combined spinal epidural that's associated with a little bit faster dilation. And when we talk about the slowing, that's usually associated with that second stage, the pushing stage of labor, not so much like, your dilation of your cervix. And you can correct me. My understanding is it could prolong it by about 40 minutes, as opposed to, as you said, it doesn't mean 2 days. And if you've been in labor for 17 hours, you're probably not going to notice that difference that much.
That's what I was going to say. I was going to say the slowing down at that point is welcome, because it allows you, it's not so much slowing that as much as that for me, it allowed me to just collect myself and like recharge in that moment instead of get rushed through kind of. But I was going to say too, shout out to the doula in the room, because that was a big part too of navigating. We were talking about, we didn't get to talk a lot about like the unmedicated or other kind of labor or pain techniques, but my doula was on my phone, and I'll let you speak to that. But there were a lot of things that I had support from kind of from afar that just helped me in terms of just moving my body, showers, baths, like other kind of ways to manage the pain. Transition.
Yes. So I want to kind of hark back to what Dr. Michelle had said at the beginning of this conversation, which is so funny how everything comes full circle, doesn't it? When she had mentioned that when she has these conversations about what pain medication or how we're going to manage your pain, she asks, she digs deeper. It's not surface level. It's about, why do you want this? Why don't you want this? And oftentimes it's rooted in one thing or another. And that's very similar to the doula's approach, my approach with my clients. I get down to, what is going to get you to your happy place? What is going to make your heart happy, your body happy, your mind happy? If you watching Real Housewives while you're in labor makes you happy, that's what we're going to do, because that will have a very real physiological effect on you. If listening to trap music and having, a dance party is going to make your heart happy, boom. If making a checklist and making sure we're hitting some things on checklist makes your heart happy, that's what we're going to do. And so as a doula, we really do our best to make sure that we are, honoring what is comfortable to you. And just like you all said with the epidural, it's not for everyone. And in some instances, it is incredibly helpful and is the key to honoring the birth experience that someone wants. And so you might not have realized, you're a mega worrywart and you're always like this. And so this epidural is giving you a chance to relax, even if you didn't mentally prepare or you weren't mentally aware of what this event could do to you, because it's your first time, even if this is your 9th birth, it's your first time giving birth to this baby at this age in this instance, and so we do our best to use special tools. And I did bring some tools. So I brought like this little massage comb that I use to sort of give, physical comfort, or they can squeeze on it. Whenever we are preparing during our prenatal sessions with mom, I like to do what's called the ice challenge. And so that's where you're doing this exercise. I'll do another video. Audience, if you're watching this, I'm going to do another video on the ice challenge. So stay tuned for that. But we do the ice challenge because that gives me insight on how mom copes with pain. And that information is so valuable whenever we actually step into that labor. And we use all type of things. I have the essential oils because, sometimes that scent can take you to your happy place. We have massage balls. And, my biggest tool as a doula is my hands. That's the best thing that I can use. I can use my hands to help get you up, get you moving. I can use my hands to give you some gentle touch, to rub your feet, to give you hip squeezes. And the best thing I have is my voice, to be there to comfort you, to be there to help facilitate your partner in comforting you. I can't tell you how many times I've gone over to dad and been like, hey, it seems like you need a hug and it seems like mom needs a hug. So why don't you guys... And that hug, it just means so much to kind of like resetting a birth experience in a labor. And so I don't have the special and amazing tools that you guys all have with this medication, but I do have something that moms are able to use at home when they're preparing to labor. And even if you do have an epidural, I have tools that can still help you and, do what my part in helping you get that birth that you want, and or making sure that you and baby are coming out safe and sound, and that you feel that you were respected and heard and you had a good experience.
No, Lydia, I think you can't I think that you can't really underestimate the value of that, because I think when you look at medications and those kinds of things, people have to have certification, knowledge, and education and all this stuff, training to be able to use them and to learn how to use them appropriately and all those things. I think one of the things that doulas do, and I'm not saying that other people don't do it, okay, and be very clear. I'm not saying that other folks on the healthcare team don't do it. But one of the things that, our doula partners do is kind of help to recenter birthing families so that they recognize the strength that they have innately, right? So irrespective of the external things that we can bring or provide or assist, you have the opportunity to center them on the things that you do have and that you have expert knowledge in, right? So that expert knowledge is your knowledge of your body, and bringing people back to that, bringing support people into the fact that this is a family event, and using those relationships and the care and the enthusiasm about the journey, like bringing that together and letting that be the focus and letting that really be the foundation from which all the other things, take place. So I think that that's something that's really important. And I don't know that we have always recognized, and when I say we, I'll just say from a medical standpoint, I don't know that medicine has always held space or created space to acknowledge how important that really is. I think that there are definitely some areas where it's been emphasized more, but I do believe that there's a lot of opportunity that we have to kind of reimagine the experience of birth, and kind of go back to incorporating and kind of amplifying those things as being equally as important, if not more so important, than all of the tricks and tools of the trade that we learn.
Yeah. It takes a village, right? So it's a team-based care. Everyone has a role.
Yes, absolutely. And I definitely wanted to kind of before we close out, wanted to share a couple takeaways from this, that ultimately when it comes to deciding what you're going to do to manage your pain, it depends, right? It depends is the ultimate kind of high level answer while we're having these conversations. There is no direct formula that we could give you. But what we can give you are tools to talk with your provider, talk with your doula, talk with your partner. And if you listened and stuck through this whole thing, you heard so many great questions to ask your provider, so many great prompts to start these conversations. And I really urge anyone watching to continue this conversation and dig a little deeper as to why you want or don't want something. Before we close, I'd love for each of you to just introduce yourselves again, so that we all know what you do, where you are. If you have a social media tag where we can find you, I'll share mine with May, and then we will close out. So I'll start with Dr. Allison again, please.
I'm Dr. Allison Lee. I'm an obstetric anesthesiologist at the University of Pennsylvania and involved in health equity work and diversity, equity, and inclusion work. And I'm just here to, I'm very passionate about making things better for people giving birth across the country.
Thank you.
Oh, and my social media, I'm on Twitter or X at Allison Lee NYC.
Thank you.
I'm Michelle Owens. I'm a maternal fetal medicine or high risk OB doctor. I'm also the clinical director for May Health. And I just have a passion for caring for marginalized populations and for ending health disparities as they exist within obstetrics and gynecology. And I'm also on X, shout out to the X folks, at Dr. Michelle Owens. And look, I have an Instagram as well. It's also Dr. Michelle Owens. So yeah, check me out.
And I am Rachel Nance Wade. I am a mom of 3, representing the moms who had both medicated and unmedicated births. I am also the Vice President of Marketing and Doula Development here at May, and equally passionate about addressing our maternal health outcomes with these amazing colleagues of mine. And really just grateful to be in this company and to be working towards solutions that really will hopefully impact our children and our peers and all of us doing this work every day to improve our experiences and outcomes.
Yes, thank you all. Again, my name is Lydia Harris. I am the lead of content marketing strategy here at May. I am a doula. I'm all types of different doulas, so I'll just leave it at doula. And yes, everything you saw here today is the embodiment of who we are at May. We are a digital platform that was created for us, by us. And if you are pregnant and you are watching this and you're like, yeah, I need some of that in my life, head to meetmay.com to sign up and learn more. If you are a doula and you're like, yeah, I want some of that, head over to meetmay.com to learn more and see if you are eligible to come and work with us. We are so grateful to have all of you, Dr. Allison, Dr. Michelle, and Rachel. Thank you all so much for joining me today and for having this incredibly important and candid conversation. I look forward to the next time.
Thank you so much. Thank you for the doula work you do. It is so important. So thank you.
Thank you. Thank y'all.